The demand for quality healthcare in Canada and around the world will never change. We all need and deserve the best care available. But what is changing is how that care is delivered to us. Artificial intelligence, census data, and big data are changing the way practitioners deliver healthcare and the way we receive it. Welcome to the Queen's University Micro Summit Series, where we're exploring how we live, move, and connect. The team has been across 4 cities over 4 months, wrapping the final leg in Calgary next month. My name is Diana Chang, and I'm the current Queen's University Branch Alumni President, and I'm delighted to welcome you here tonight. I'll be your MC for the next 2 evenings, so I look forward to getting to know each of you after each night. I started my career actually at Queen's University as an international admissions coordinator, and across all my travels, there was one thing that really weaved all the pieces together, which was Queen's spirit of initiative and spirit of community and spirit of giving back and impact. And I think we're truly in for a treat these next few nights because the university has put together a panel of incredible speakers that are impacting healthcare and Canada and the world. Every micro summit is focused on the future, and each one will explore the future through a different lens. The next 2 nights, our focus will be on healthcare. How are AI and census and big data making healthcare better and more accessible? Before we begin, I want to acknowledge that the land on which we live and work is the unceded traditional territories of the Squamish, Tsleil-Waututh, and Musqueam nations, and we're extremely grateful for the opportunity to do so. Tonight, we'll hear from 3 Queen's researchers to share their visions of the future with you. 2 will be in person and 1 via video. Unfortunately, Dr. Kerstin couldn't be with us this evening due to a personal emergency. However, given how closely her topic aligns with tonight's theme and the significance of her work, we wanted to make sure you still had an opportunity to experience her. Each talk is roughly 15 to 20 minutes in duration, and I'll be introducing each speaker before they come up. So let's get started. Our first speaker is Dr. Kerstin Donnelly from the School of Rehabilitation Therapy at Queen's Health Sciences. Dr. Kerstin Donnelly is Associate Professor and the Director of the Health Services and Policy Research Institute. Her clinical research focuses on team-based primary care and supporting older adults and individuals with chronic conditions. Give it up for Dr. Kerstin Donnelly.
Eleanor Rigby died in the church and was buried along with her name. Nobody came. All the lonely people, where do they come from? I had heard that Beatles song countless of times, but it wasn't until I was at a talk on loneliness and aging that I really listened to those words. I want you to stop for a moment and pause and think of your neighbors, family, friends. It is almost certain that you yourself know your own Eleanor Rigby. My name's Kerstin Donnelly, and I'm an occupational therapist and health services researcher. And I'm here to share a story with you about a man that I'll call Frank. I was working at the Queen's Family Health Team as an occupational therapist, and I received a referral to see Frank. He had a number of chronic conditions and was having difficulties doing some of his day-to-day activities. He was having trouble walking around his apartment. He was having trouble getting into the shower, making meals for himself. Frank lived alone in an apartment, and his wife had died a number of years ago. He absolutely loved to carve wood, and he had a whole room dedicated to his wood carvings. But money was also tight for Frank, and he often found he couldn't do the things that he wanted or needed to do. He had very few social connections. He knew the neighbor next to him. He had a nephew that was about an hour away, and that was really the only relative he had. He didn't have children. And that relative would come the odd time to take him to some health appointments or help him with some heavy lifting. Frank was both lonely and socially isolated. Loneliness is a feeling that we experience, and social isolation is the number of connections that we have. Loneliness. It's been called a global health issue, an epidemic. The US has recently put out a paper identifying loneliness as the next public health crisis. We don't know the exact magnitude of the problem, but the numbers estimate that approximately 1 in 3 people are experiencing feelings of loneliness. Likely someone here in the room are feeling lonely in some sort of way. And we know that since the pandemic, feelings of loneliness have only increased. And in older adults, we know that older adults feel lonely in higher numbers and for longer periods of time. It is shocking, the impact of loneliness, and many of you might have heard this recent statistic. Well, it's not recent, but it's been in the news, that loneliness puts you at risk, or poor social connections put you at risk of an early death, the equivalent of smoking 15 cigarettes a day. Simply put, you actually can die of loneliness. And we know that older adults are living alone longer than ever. Longer and alone. And we know that's in part because the demographics are changing, but we also know the social fabric is also changing. People are born to connect. So when we think about social isolation, we think about solitary confinement. Literally is a form of punishment and torture. Just going to check my notes because my brain is slightly jet lagged. We know that loneliness impacts all ages, but we know that older adults, again, are more prone. And I'm here to share with you my research on loneliness as we age. Because in the same building that I saw Frank, I also saw Tilly. I also saw Jane. I also saw Manuel. And while each of them lived on their own separate floor, and none of them knew each other. So I would go and see Jane on the first floor, Tilly on the second, and Manuel on the fifth. And then I would see Joan in a house by herself in a neighborhood with houses all filled with older people, that at once that neighborhood was filled with children. And so I knew each of them, but they didn't know each other. And as healthcare providers, one of the key foundations is that we maintain confidentiality. And so I couldn't actually connect them. And so I didn't have a way or an intervention that I could think of that could bring them together. So I continued to work with each of them on their own. I knew them, but they didn't know each other, even though they were living together. And so while we know quite a bit about describing and understanding the concept of loneliness, we know much less about what we can do as a society, as healthcare providers, as individuals to address loneliness. And so while we know loneliness shortens lives, we know that relationships can extend and are what matter. You might have heard that the longitudinal study on adult development by Harvard followed almost 300 men starting in 1938, one of the longest running studies, still going to this day. And what they found was that at age 50, men who were the most satisfied with their relationships were the healthiest at age 80. Relationships, when you nurture those, you're actually literally nurturing your own health. Frank wanted to live on his own. He wanted to age in place, is what we often say. He wanted social connections. But our society typically focuses on the individual. So we think of programs that we create, we deliver programs for the person. We rarely think about supporting our neighborhoods and thinking about the collective. So while I worked with a team of other health providers, pharmacists, social workers, dietitians, we all worked with Frank individually, doing our best to, what I say, treat the tipping point issues. So we were able to keep and support him in his home, but we didn't fundamentally address the core issues of loneliness and social isolation. I'm an associate professor at the School of Rehab and also teach in the Aging and Health program. And I was teaching a course called Evaluating health-related programs for older adults. And one of the assignments that I created for the students is that they needed to spend the semester identifying a program in the community supporting older adults. And that year is reading through, and each year they have every 2 weeks, they submit another part of their assignment. And so over the course of the term, I got to learn about a program called Oasis Senior Supported Living. And as I was reading about that program, all the pieces fell into place. And I immediately thought of Frank, because Oasis is about a program designed to address issues of loneliness. And it's designed to address issues of loneliness where people are living. And so myself and my colleague Vince DePaul, who's not here today, but he and I are very close colleagues and have done this work collectively together. We reached out to Christine McMillan. And Christine McMillan was the founder of Oasis. And she, and together with older adults living in, and this is maybe a new term for everybody, naturally occurring retirement community, or a NORC, we affectionately called them. So older adults living in a NORC created this program. And what they designed was, again, for anyone who hasn't heard of a NORC is a geographical area that has a high proportion of older adults. So that might be, like I was mentioning earlier, a neighborhood that has aged over time, and you can think about your own neighborhoods that you live in. And so again, they grow and change. Or it could be, for instance, an apartment building that older adults or older people naturally move to. It might be close to amenities, or maybe it's a building that people lived in and then again have grown old together. And NORCs are a great place for us to think about how to support older adults. Again, thinking about how to bring people together where they're living, but also how we think of bringing services into naturally or NORC programs. And so Oasis has 3 pillars. It's looking at nutrition, physical activity, and socialization, all done in groups where people are living. And so Christine went to our local health authority, and she was able to secure funding to hire an on-site coordinator. And that on-site coordinator enacts the programs that the older adults themselves want to host in their building. The foundations in terms of philosophy are empowerment and self-determination. So again, older adults know best what they want. And again, the on-site coordinator enacts. Sometimes they have programs that they themselves volunteer. Sometimes we bring outside programs into the building. And it's a collaboration with the landlord partners who are core to this. And we actually have one of our lovely landlord partners, 2 of them actually here today from the city of Vancouver and Brightside. We run programs here in Vancouver, which I'll talk a little bit about in a second. And so Oasis is about a program to address loneliness. It's not a health program, but it has health outcomes. So my colleague Vince and I thought to ourselves, it had been working magically in one building in Kingston, Ontario. And we wanted to see, could we potentially look at spreading this to other buildings across the province? So we worked with the Oasis Board of Directors, and we went on, for anyone who applies for research funds, it took us a little bit of time, and we were eventually successful in 2018. And we were able to secure $1 million to expand to 6 new communities. We worked with our colleagues both at Western University and McMaster and started to think about how we could expand to different communities in Ontario. So we spent that summer meeting with all of the Oasis members in that original community, listening, learning, documenting all the key ingredients so that we could spread that program to the other communities. So one of the core pieces of Oasis, as I mentioned, were NORCs. So how do you identify NORCs? And this is where the idea of big data comes in. So we were able to use Canada Census data to identify small neighborhoods or geographical units. And we were able to use some of that socio-demographic data to understand where were those neighborhoods where older adults were living and what were some of those socio-demographic criteria. So we mapped those out in Kingston, we mapped them out in London, and we mapped them out in Hamilton. And we were able to pinpoint buildings in those areas. And so we've since expanded that work. So we've had a biostatistician working with us. And again, this is freely available public data. And we've since mapped the entire province of Ontario. And we've mapped them over 4 census years. So you can actually see how neighborhoods are changing in terms of demographics. And you can see pockets, again, where there's differences. And we've also done that in Nova Scotia, And so the whole province, you can go on our website, and we've also mapped out British Columbia. So you can actually look in, when you leave today, you can go and check out your neighborhood, and you can check out the different census years to see how that's been evolving over time. Well, one of those neighborhoods was the neighborhood Frank lived in. And so we called up the landlord, cold called the landlord, and we do that, and we asked the landlord and explained what the Oasis program is. And we described it and asked if they would be interested. And they were. And what that meant is that they offer and donate free space, so the common space in a building. And we provide the funds to hire the on-site coordinator. So began our connection working with Frank. And so what we do in all of our buildings, and we've learned from these early lessons, we put up flyers, because the idea is to create a community where people are living. And so we literally put flyers, and we can still attest to how we do this to this day. Post flyers in the laundry room, by the mailboxes, put them under the doors, and we host a series of information sessions. Again, because it's for and by the older adults, it has to be something that they want. And so we describe the program, head planning, and with all events, like this one too, you think to yourself, if we build it, will they come? And so when we put up the flyers, we weren't sure how many people were going to be coming. More importantly, we weren't sure if Frank was going to arrive. Or I wasn't, because again, I couldn't reach out for this specifically. But that first planning meeting, Frank, by then he was 90. And he came in and he was sitting on a walker. This was the original building here. He sat in the corner, for he didn't know anyone in his building other than his neighbor, and that was by name only. So over the course of that year, Frank developed a community. They decided their Oasis group, and every Oasis is slightly different, they wanted to have morning coffees and newspaper chats. So he would come 3 mornings a week, and once a week they had an art drop-in. And in that art drop-in, he brought his wood carvings, and he became a mentor to the other people in the building. And so, again, Frank had a community. And so even though by that time he was unable to drive, he had developed a community who was able to take him to places that he wanted, where he needed to go. For Oasis isn't about providing services to one person, for instance, dropping a meal off and having a person eat by themselves, or hosting an exercise program that someone goes to and then comes back by themselves. It's about building a community where they're living and offering services and programming in that place. By 2020, COVID had hit, as we can remember distinctly, and we were particularly worried about Frank. And so I had 2 occupational therapy students with me working on placement at that time, and they immediately created a list, if people had wanted to be on it, to be on the calling list. And I remember our project manager at the time, Simone Parniak, who was incredible, and reached out to Frank and spent hours on the phone training him how to use Zoom. And he eventually got to use Zoom. Part of what we wanted to do was find out, could we spread Oasis to other sites, which we found we can, and I'll share a little bit more about where we are today. But we also wanted to do evaluation to find out, what was the impact of Oasis on social connections, social isolation, health outcomes? We conducted a series, and we've been doing quite a bit of research, and I'll again talk a little bit about that today. We conducted some early interviews with Frank and people in his building and some of the other buildings that we were working with. And what we heard was 3 key themes. We heard that Oasis gave people something to do and someone to do it with. We heard from Louise that she looked forward to Monday mornings because it gave her a reason to get out of bed and something to do, so she didn't have to stay in her house alone. We heard from people that it helped them cope with life a little bit better. It gave them something to get up in the morning for. And over again, we heard that Oasis strengthened and deepened connections. We heard that people felt like Oasis was like a family to them. And for Frank, Oasis became like a family to him that he didn't have. And shortly after the pandemic, Frank was hospitalized briefly, not for COVID, for his other health conditions. And up until the day he passed away in the hospital, he was receiving calls from the Oasis members. Frank died in the hospital, but having lived at home just as he would wanted to. And like Frank, most older people want to age in place and want to stay at home until they pass away. We also wanted to see if Oasis could do that. So we have also been looking at some of our data and some of our outcomes to see if Oasis can extend people living at home. We've been able to use large data, large health administrative data. It's something in Ontario called ICS. And what it does is we can able to track people's use of the healthcare system. And what we found is that older people who were living in the original Oasis building, who eventually went to long-term care, were able to live in their home for a median of 1 year longer than people who were matched living in buildings without an Oasis program. We also found that people in an Oasis program had fewer hospitalizations, fewer emergency department visits, and almost 50% use of home care. So not only, again, are people feeling less lonely and more connected, they're actually developing networks that help each other. We've been very fortunate, so we've been continuing to do that research, and these are just some of our preliminary findings. We're just finishing a 5-year longitudinal study funded by the Canadian Institute of Health Research, where we're looking at members who are in Oasis buildings and comparing matched sites and following them longitudinally over time, looking at how their networks grow and change, looking at how they use healthcare differently, and a number of different health outcomes. So what started as one building in Kingston with about 50 members is now up to over 23 communities and growing. So we have Oasis communities in Nova Scotia, in Halifax, Dartmouth. We have in Ontario, some are growing in Alberta, and we've got 4 Oasis communities here in Vancouver, working with Brightside in the city of Vancouver. We also work with our community partners, the Collingwood Neighborhood House here and West End Seniors Network. We have received over $10 million in funding to spread Oasis and to evaluate it, and we're in the midst of creating an Oasis not-for-profit, a national not-for-profit that will be populated and supported by the members themselves. I always feel funny standing up talking about Oasis social connections by myself here, because it would be disingenuous for me to say on my own that I have done this, and I am remotely just here as a representative of the incredible network of partners that we have, landlord partners, service partners, and the strength of the older adults. It's one of those lifetime projects that you only hope to achieve and be able to see the impact of the work of the collective, truly the collective. We think of the city of Vancouver, and I just want to also have a nod here. Again, the strategic framework in terms of thinking about older persons, and one of the key focuses is on loneliness and social connections. And so again, when I think about the city of Vancouver, I think of the incredible work that's being done to support older people here. We started this talk by thinking of Eleanor Rigby, and I got you to think about your neighbor, maybe yourself, family. I'm going to get you to think of each of those people as you leave here today. And again, there is no magic bullet to fix the feeling of loneliness, but each of us collectively can think about how we might reach out as we leave here today to think about your own Eleanor Rigby. Thank you very much.
Thank you so much, Catherine. That was wonderful. And congratulations on such significant impact that, starting small in Kingston and how it's spread across the nation. So we look forward to exploring more within Vancouver as well. As mentioned, our next guest speaker was unable to join us in person, so instead we have her here on video. Dr. Kerstin de Wit is a professor in Queen's Health Sciences in the Department of Emergency Medicine and holds a Canada Research Chair in Emergency Venous Thromboembolism. This evening, Dr. de Wit is going to share how she and her team are taking AI to the emergency department to diagnose one of the most commonly misdiagnosed medical conditions. Let's take a look.
Imagine this. One cold December evening, you're carrying your garbage out to the roadside and you realise that you're struggling to breathe. And as you walk up your stairs to go to bed, you become dizzy and winded. The ambulance takes you to the emergency department, where you're diagnosed with pneumonia. You're started on antibiotics and sent home again. But 3 days later, when you get up out of bed in the morning, you become very dizzy and you pass out. On your second visit to the emergency department, the doctor organises a lung scan and they tell you that you have blood clots in the lungs, not pneumonia. You overhear a staff member comment that you're lucky to have survived. My name's Kerstin de Wit. I'm a professor in emergency medicine at Queen's University, and I've been studying emergency blood clots for most of my career. Let me tell you about my journey. One summer, when I was a medical student in Scotland, I was sent to work in a community hospital. The hospital was set in a beautiful green field beside an old Scottish town at the foot of 3 ancient hills. These hills were once the home to a Bronze Age fort and then a Roman fort, and are now deeply ensconced in the local folklore. The hospital was very small, and patients lay in their beds, gazing out of the window at rabbits grazing in the field. And the nearby River Tweed meandered through the countryside. Every morning at 8 a.m, I joined the ward round, where doctors all dressed in white coats gathered in order of seniority to join the staff doctor and walk from bed to bed. It was the most junior doctor's role to push the trolley that contained all the medical records for each of the patients. The staff doctor would stop at the end of the bed, speak briefly to the patient, bark questions at the assembled audience, and then declare what the next steps were. An exercise test for a man who came in with chest pain, a brain scan for a woman who became confused, and a lung scan for a man who's feeling short of breath. The junior doctors scurried around in silence, sometimes organising the tests as the ward round progressed, and other times adding to their list of work for later in the day. We were wrapping up at the end of the day when the results of the lung scan came back, having diagnosed pulmonary embolism. You'll hear me talk a lot about pulmonary embolism, but for now I'll tell you that pulmonary embolism is blood clots in the lungs. Something wasn't right about the scan report. It had the wrong patient name, and it took us 5 minutes to work out what had happened. The junior doctor had accidentally used the wrong patient identification sticker when they were writing out the request for the lung scan. So the patient in the bed next door to the patient who was supposed to have the lung scan actually had the test. And it turned out that the patient in the bed next door had pulmonary embolism. And what about the man who was supposed to have this test? Well, he turned out not to have pulmonary embolism at all, and we'd actually stumbled on the diagnosis in his neighbour by mistake. And this was my introduction to diagnosing pulmonary embolism. Pulmonary embolism is a condition that happens when the blood starts to clot too much. Everyone knows that the lungs bring oxygen into our blood, but few people know that the lungs are actually our blood's filter. And it's the job of the lungs to remove anything solid that's traveling in our bloodstream. So when the blood starts to clot too much, pieces of blood clots move with the blood flow, and it's our lungs' job to remove these pieces of blood clot to protect us against having a stroke or a heart attack. So when there's abnormal blood clotting, the first place that the blood clots show up is in the lungs, and that's right where they're supposed to be. This condition can be treated easily with tablet blood thinners at home. But very occasionally, the lung filters get so clogged up with blood clots that the blood flow can't move easily through the lungs. And when that happens, pulmonary embolism can become fatal. I'm going to move forward in time 20 years from when I was a medical student. I'm now living in Burlington, Ontario, and I'm working as an emergency doctor. My husband and I live in a small house in a road that's lined with rambling lots, all backing onto a forest. Our neighbours are retired, and this is a close-knit community. In the summer, we all go round to Dave and Betty's house, where we enjoy fresh Italian food and homemade tomato sauce. Betty and I exchange notes on the oriole birds, and we're wondering when they're going to fly south again. In the winter, we cross the road to Ben and Helen's house, where we enjoy Helen's holiday decorations and have a drink. I find a store next to the hospital, and it makes authentic Scottish haggis. So every January, everyone comes to our house for a Scottish burn supper. I was working on a grant at the kitchen countertop when Ben, my neighbour, knocked on the door. Something was wrong with Helen. We walked across the road together, and we found Helen sat in the living room chair looking upbeat and healthy. She told me that she felt short of breath walking up the stairs carrying the laundry. I took her pulse, and we agreed that she would keep the appointment with the family doctor that afternoon. 2 days later, I had a voicemail from Ben telling me that the family doctor had admitted Helen into hospital. And then later, the following weekend, I was stood in Toronto train station when my neighbour Betty called me, and she told me that Helen had died that day in hospital, and that she had died from pulmonary embolism that was diagnosed too late to make a difference. And this brought me back in time to when I was a medical student 20 years beforehand, when all the doctors on the ward round missed that a patient had pulmonary embolism. How could I have known that Helen, my neighbour, had pulmonary embolism? Well as being an emergency doctor, I am a pulmonary embolism expert doctor, and I treat patients from across our region with this condition. And I have been researching how to improve the way we test for pulmonary embolism since 2001. I eat, sleep, and breathe pulmonary embolism, yet I missed the diagnosis. How can I explain that I, an expert in pulmonary embolism, missed the diagnosis? And what's the impact of missing the diagnosis? It seems to me that missing the diagnosis of pulmonary embolism is quite common, because many of my patients who I see in clinic have visited more than one doctor before the diagnosis is made. Pulmonary embolism is confused for a heart attack, pneumonia, or asthma more often than we think. But when the heart tests come back normal, when the pneumonia doesn't get better with the antibiotics, or when the asthma doesn't respond to inhalers, the real diagnosis is made. Most of the time during that delay to the proper diagnosis, there's little impact on physical recovery. But misdiagnosed pulmonary embolism can leave people with long-term anxiety and mistrust in the medical system. And very occasionally, the lung filters become so clogged up with blood clots that patients can die before the diagnosis is made. To understand how pulmonary embolism can be misdiagnosed, you have to know that pulmonary embolism gives people shortness of breath or chest pain, or it can make them faint. But by far the most common symptom is tiredness. And who here has never felt tired before? And I'm sure most of you have never had pulmonary embolism. The symptoms vary from one person to the next, and the symptoms are very common in people who book into the emergency department. And if we tested every person with these symptoms, then the waits for the scan would be weeks or months, and the whole system would grind to a halt. And people would have lung scan radiation without any benefit to them. So doctors have to use their clinical acumen to decide who should be tested for pulmonary embolism. In my research, the strongest message that I get is that emergency doctors are anxious about missing pulmonary embolism. They tell me that pulmonary embolism is the boogeyman of the emergency department, and they talk a lot about cases that are misdiagnosed. They see their role as spotting serious diagnoses, and failing to spot pulmonary embolism is failing as the emergency physician. But paradoxically, this anxiety about testing for pulmonary embolism is getting in the way of making the real diagnosis. Pulmonary embolism is a wicked problem. Only 2 in every 1,000 people who book into the emergency department have the condition. The symptoms are suggestive of other diseases, and examination by a doctor is almost always completely normal. This is where I'd like to tell you about Dennis. Dennis is a retired app developer and a member of my running club. I'd never really met Dennis, but I had seen him in the past taking club photos as we worked out on the track, and a common friend suggested that he talk to me. Dennis had been admitted into hospital with shortness of breath and misdiagnosed as having a heart attack. And it was 2 more days before his doctors realized he actually had pulmonary embolism. Since that time, he had followed stories in the newspapers about people who had died after they had been sent home from the emergency department with misdiagnosed pulmonary embolism. And he had wondered whether artificial intelligence could help doctors spot these cases. Dennis realized that doctors weren't always testing the right patients. If the right patients were tested, then lives could be saved. So we set about together to work on this. We gathered a small team with expertise in big data and emergency research. We analysed over 14 million emergency department visits in Ontario. And we worked out that every year in Ontario, there are more than 1,500 cases of misdiagnosed pulmonary embolism. We looked at the risks for somebody booking in with pulmonary embolism, and we identified these as the person's age, their symptoms, the triage nurse assessment, whether they've ever had a blood clot diagnosed in the past, having cancer, or having had recent surgery. And we put each of these risk factors into an AI model, and we found that this model helps guide doctors test the right patients for pulmonary embolism. We call our AI model PE Nudge. What if PE Nudge could work behind the scenes in the emergency department as a patient books in? The model would examine the medical records, and when it identified a person who was at risk of having pulmonary embolism, it would send a screen message to the doctor. Have you considered pulmonary embolism? Sometimes breakthroughs come from where we least expect them. Dennis knew nothing about the many years of research and hard work that's gone in to try to improve the way we test for pulmonary embolism, and to him it was obvious we need to test the right patients. It's been a steep learning curve. Dennis has had to learn to work with medical data and the restrictions around its use. Many of his good ideas have been thwarted by regulation. Our research team has learned to work remotely across Ontario. Our highlight was when Dennis presented our results to the Ministry of Health in Ontario last year. We're the only research group in the world who are working to guide emergency doctors on who should be tested for pulmonary embolism. We need to make PE Nudge the best it possibly can be at identifying pulmonary embolism. This research is challenging because we need to enroll hundreds of thousands of people booking into emergency departments across many hospitals. The research is expensive and we're looking for funding. We're not afraid to do this research because we know we can make a difference. Imagine this. One cold December evening, you're carrying your garbage out to the roadside, and suddenly you find yourself struggling to breathe. And as you walk up your stairs, you become so dizzy and winded that you collapse to the ground. The ambulance comes and takes you to the emergency department, where the triage nurse records what happened to you. Within minutes, a doctor appears at your side because the system flagged you as potentially having pulmonary embolism. An hour after you collapsed, you are diagnosed with pulmonary embolism and treatment is started. It takes weeks for you to recover, but you know you're safe, you have full trust in the medical system, and you're looking forward to your future. Pulmonary embolism is difficult to diagnose, and sometimes people die before the diagnosis is made. PE Nudge is an AI model designed to help doctors spot pulmonary embolism. If we succeed in our research, then one day in the future, emergency doctors will say to all their patients with pulmonary embolism, "We've got this, you're safe in our care, you're going to be okay."
What a great example of the intersection and power of AI and the healthcare system. Wonderful. Thank you, Dr. Kerstin. How many of us have had to wait unnecessarily long for a doctor? Just Lauren? Just Lauren? No more. Yeah. Our next presenter is going to share with us how his team is using AI to fix that. AI-assisted triage program that is helping dramatically reduce wait times, specifically for patients with mental health conditions. Dr. Vedat Verter is the Stephen J.R. Smith Chair of Management Analytics and a professor at the Smith School of Business. Vedat's interdisciplinary background and approach has given him a holistic and unique lens to solve this very problem. Vedat specializes in applying operations research and data analytics to support policymakers in the public sector. His main research includes socially responsible supply chains and healthcare analytics. So with that, let's introduce our third and last speaker tonight, Dr. Vedat Verter.
Sarah lives in Kingston, and she's a strong and bubbly person. Except for about a year, something changed in her and she feels quite exhausted. Not very much willing to eat, so she thought this was a phase and she would just push it, she would just shake it, but it wasn't really going away. But nevertheless, she showed up for work. She did her best. She showed up until she couldn't anymore. And one day she broke down in front of her mom, at which time she agreed to go see the doctor. The doctor listened to her sympathetically and prescribed an antidepressant and said, "Let's try this for about 6 weeks, and hopefully this will help you." Sarah was upbeat that day, but she wasn't 6 weeks later because the antidepressant didn't really make a difference. So the doctor said, "Well, okay, let's try another one. This is a different family of antidepressants, so we'll try this one, and hopefully this is going to work for you." And that didn't work either. So after the third trial, the doctor agreed to refer Sarah to a psychiatrist. Sarah was again crushed when she found out that she had to wait for 14 months in Kingston to see a psychiatrist. Now, this is not a unique story. Many of us would have known someone who went through something like this, or maybe some of us gone through this. What I know is that 6.7 million Canadians suffer from a condition related to mental health annually. Now, what does this have to do with a business school professor? I am trained in operations research and management science to tackle complex and multifaceted problems, and what can be more complex and multifaceted than Canada's problems in healthcare. So that's what I specialize in. It's a fantastic field because everything is so difficult. I have worked at McGill University in Montreal for more than 2 decades at the beginning of my career. And there I worked with most of the tertiary hospitals, of course, in the English side. And we have done some work at the Jewish General Hospital where we developed a simulation program, which is called a digital twin these days. We work with their surgical services department to balance the nurse workload. But for the purposes of today's talk, I think the most relevant work I did in Montreal was with the Douglas Mental Health Hospital on their clinic for the treatment-resistant depression patients, and with the Jewish General Hospital for their continued care clinic on the schizophrenia patients. From Montreal, I moved to Lansing, Michigan, to become a department chair. And I did that for 3 years. Those 3 years coincide with COVID. All of our medical partners were fully occupied saving lives. So I have absolutely no research results to report on for those 3 years I spent at the Michigan State University. And so then I joined Queen's University Smith School of Business 3 years ago. And upon arriving, I wanted to develop my network of connections in the health space. And that's when I met the people in the adult psychiatry division of the Kingston General Hospital. They have an online psychotherapy lab there where they have developed more than a dozen digital modules that could be used for providing online cognitive behavioral therapy. And that expertise actually establishes the foundations of the work we did with them afterwards. So our medical partner in this space is the adult psychiatry division of the Kingston General Hospital. And this piece of art is actually supposed to show you, just in case it's too modern, that you need a team to deal with these kind of challenging problems. And the challenging problem you see there is the waiting line. So in addition to the medical partner, I also met a technology partner where it's called OPTT Health, and they develop large language models specializing in psychotherapy and psychiatric triage. So it is this team of 3 sub-teams where we have the management school, the technology vendor, and the medical side. We worked on developing an AI-assisted triage program to deal with the 14-month wait time for the patients at the Kingston General Hospital, where there was 1,200 patients in the lineup. So when you're referred to a psychiatrist at the Kingston General Hospital, there is 1,200 patients roughly in front of you. So this is my most impressive slide. If you're not impressed with this, then it's going to be downhill from here. So this is the process flow of the care delivery for patients of the psychiatry division. And as you would see, from the left, the patient is referred to the psychiatry division, and a triage starts the process. That triage takes, on the average, 45 minutes by a registered nurse. And so basically this particular research project I'm talking about today is to replace that in-person triage with an AI-assisted triage that the patient will do online. And so that at the end of that triage, where the technology vendor's large language model is utilized to go through the patient's narrative in terms of the symptoms they're feeling and the changes over time. So basically, the patients are able to either voice record or type the narrative, and then the large language model analyzes or text mines that and identifies 3 different care intensity levels and disorder-specific psychotherapy tools to the patient. So these 3. This is what I'm talking about. And then once the patient actually completes this, then the patient is directed to a 10 to 12 week online cognitive behavioral therapy tool. Now the care intensity changes from mild, moderate, and severe patients in the sense that the mild patients need to, the target is that the mild patients would see the doctor in 6 months. The moderate patients will see the doctor in 3 months, and the severe patients will see the doctor in 1 week. And the other thing, so basically, as you can see after that rectangle, it splits into 3 pieces. And the other difference between the mild and moderate and severe patients is that the higher intensity 2 groups involve the weekly meetings, virtual meetings with the therapist. Right? So the mild patients only do the cognitive behavioral therapy. The moderate and severe patients, in addition, are overseen by a therapist. And in terms of the target, one needs to see the patient, the physician, if necessary, in 6 months, the other one in 3 months, and the other one in a month. Now, what I forgot to mention is that at the triage, one of the things that's done is that it's also trying to identify the high-risk patients who need to see a psychiatrist immediately, right? So if you are a high-risk patient, then the AI-assisted triage would flag the care team, and you would be directed to a psychiatrist immediately. So this is the setup, and what we have done is that we have recruited 100 patients out of those 1,200 patients waiting in the line who would agree to use the AI-assisted triage. And upon completing the 12-week psychotherapy, some patients did not need to see a physician, a psychiatrist, and so therefore they were referred back to the primary care physician who referred to them to the psychiatrist. Some patients needed to see the physician, and they were directed to the psychiatrists in terms of the urgency of how quickly they need to see that. So, as a result of this, we were able to cut the 14 months wait time to 8.5 months. That's a 5.5 month reduction. in the wait time. And the key here is that we were able to take out the patients who did not need to see a psychiatrist out of the waiting line. And that turns out to be 2/3 of the patients. So it's the 1/3 who really needs the higher intensity level of care, and the ones who need the higher intensity level of care were waiting for those who were referred to the system because their primary care physician didn't know what to do with them, right? So basically, the patients have waited for the pilot study, the 100 patients. They're waiting less. The 45-minute registered nurse triage has been taken down to 6.5 minutes. The weekly visits with the therapist, which were an hour each, were taken down to 15 minutes. And this means that those care providers are now able to free themselves up from these tasks and provide access to other patients, right? So it is good for the patient, but it's also good for the care providers. There's also an economic perspective to this, in that we were able to estimate a $17,000 saving per patient, which basically totals up to about a $2 million saving to the economy. Most of it does not come from the savings you achieve in the nurse's time. Most of it comes from the productivity that you prevent from losing by providing treatment to these people much earlier. So that's where the savings are, not that you reduced some nursing time from 15 minutes to 7 minutes. Now, most importantly, the 3 high-risk patients in the 100-patient population that was identified by the physicians was also identified by the AI. So the AI actually performed amazingly well in terms of identifying the high-risk patients. We also have compared the AI's recommendations with the psychiatrist who looked at the same patient's triage and said, I will call this a moderate patient, and I recommend to see this patient to see a physician in 3 months. Those matched the human psychiatrist's assessments 75% of the time. So the AI worked with a 75% accuracy and achieved a significant reduction in the wait line by identifying correctly the patients who would benefit from cognitive behavioral therapy but not necessarily need medication to be prescribed by psychiatrists. Now, where do we go from here? Well, I would like to develop a slide that's even more impressive than this. But the idea is that this waiting line in the psychiatry division is happening because 40 to 50% of the patients who went to a family physician, if they have one, and if they don't have one, they'll go to emergency. They will have to go to the emergency department, are referred to a psychiatrist. Let me repeat that. Half of the people who express they have a mental health condition will be referred to a psychiatrist by the doctor, family, or primary care provider. So what we would like to do, or what we are working on doing right now, is actually focusing on the left side, the initial phase of this, where now we would like to help out the primary care physicians with the AI-assisted tool so that they could actually do better in terms of determining what path the patient should follow and whether the patient really needs to be referred to a psychiatrist or not. Because if you don't keep referring the patients to a psychiatrist when it's not necessary, and in our case, about 60 of the 100 people actually was those cases, then maybe you'll have a much shorter waiting line. And so the people who really need intensive care will be able to receive that care. Now, this is one effort that we're focused on right now. And the other one is, of course, we're focused on scaling up the pilot study to make a difference in Kingston General Hospital. To the extent that we would do that, maybe the next Sarah, maybe the next, sorry about that. There's an even more impressive animation in that slide where Sarah smiles. Now, I was here at 4 o'clock and we did 2 rehearsals. We never managed to make Sarah smile because the slides were done at Queen's, and of course we're using a different computer here. But at the, so maybe the next, oh, she did? Right, she did. Well, if you wish, it happens, right? So maybe the next Sarah, to the extent that we could do this, is not going to wait for 14 months. Maybe the next Sarah will be able to have access to timely and the correct intensity of care in a much more timely fashion. This is the type of future that we're trying to build. It's not because we replaced human care with AI, but it's because we amplify human care with AI. And that's important because no one should wait to be heard. Thank you.
Thank you so much for that. That was great. You're saving time, you're saving money, you're making people smile, all good things. These 3 talks have really given us something to think about, and I think for those joining us tomorrow, we will be delving deeper into conversation and Q&A, but for tonight, I did want to open the floor just for a couple questions. So we will invite our speakers back on the stage, Catherine and Vedat, and I'll open the floor up to questions. Please feel free to direct to our speakers directly. All right.
One of the things I always observe as an outsider in from the healthcare industry, I'm not mostly a technology guy, is these realizations and research efforts and results. They're fantastic and incredible and really inspiring. It feels almost as well like they're bounded and what prevents this stuff from kind of expanding into more holistic improvements in outcomes in the healthcare industry? Well, there's probably a million things, but you could comment on that.
So I think, are you referring to broad scale implementation? So it becomes routine practice.
That, but also there are these sort of almost siloed efforts, and they each produce fantastic results. Whereas, if you look at the industry, the tech industry, they have breakthroughs where all of a sudden everyone benefits from some new thing, and hopefully the AI can help with that. But it seems like even the implementation of AI and other technologies in healthcare seems it's too siloed to have a broad impact. So that's kind of my impression as an outsider. And I so want all of these individual successes to become more broad-based.
I don't know if people have heard this term, but they often say in healthcare, Canada is a system of pilot studies. Because we often hear one pilot study, and oftentimes it's partly the way our funding is, to tell you the truth. So often for Oasis, we've been able to have sustainable funding for about 8 years now, but many of the funding sources require new innovations, which sound compelling from a funding perspective, but what it doesn't do is provide sustainable funding for programs we know work. And so that's part of the challenge. And then part of the challenge is working across provinces. Healthcare is provincial. So it's hard to scale broadly across Canada. So like, I'm just thinking of our work in Oasis, like we have to understand each of the provinces and how the nuances work and work province to province, and policy changes have to happen separately. So that's, I can go on actually for quite a bit, but those are the two pieces. And again, I work in the policy world and implementation world, and it's challenged to get base funding from a health system from these innovations that are research related, because it's publicly funded, it's not like a private industry.
The private sector needs to step up. Yeah, we're.
So, I think your question intrinsically relates to what the universities are supposed to do and what they're not supposed to do. So, when the reason why it's a haven for pilot studies is because that's what we're supposed to do. We're supposed to figure out how it needs to be implemented, what's the method, what's the technology to be put in there. But then after that, it is that institution where we show that this is working on a small sample. You need that institution to make the necessary commitments to actually scale it up, and that's exactly where we are in terms of the project that I mentioned. Now, what makes the difference is that the pilot project is done by a small team of psychiatrists, in addition to us. Now, it has to go from that small team of 4 psychiatrists who looked after those 100 patients to the team of 11 psychiatrists who's actually providing care for the 1,200 patients in the green line. And you know, there are issues around the hospital administration's commitment to that, and there are issues around how many medical doctors are there? Medicine is a collection of egos. So, really, I thought you were from nursing. So the idea is that there are also issues around scaling up, because there's a selection bias about those 4 people who wanted to do that work with you, and they're open to the use of AI, for example. And the other 7, some of them are actually dead set against using AI. So it's not as simple that like in a car manufacturing plant, the vice president of operations may wake up and say, next Monday we're going to start doing just-in-time manufacturing. And it's his purview or her purview to do that. Now in a hospital environment where there are so many stakeholders, each with quite similar power, it's a very different dynamic to scale things up. And you're absolutely right that healthcare is very slow in scaling things up. Thank you.
Lauren, what did you want to ask?
Thank you. Is Vedat your name?
I'm Catherine.
Catherine. Okay, sorry. I was wondering, with your study, what where do you see age race from about, is it from 80 to 100 or 70 to 100? What's the age rate?
So it's an interesting question, because depending on the community we work in, we actually don't have 65 per se as the age category. So we work with communities that have lots of disadvantages, and someone who's 40 might look like, because of frailty, might look like someone who's 60 or 70 or 80. So we have any age range from early 40s all the way up to over 100.
Have you found that the program to run has actually helped in terms of longevity, in terms of living longer?
So we haven't looked at this stage, we're just in our last of the years for longitudinal studies, so we haven't looked at death actually as an outcome. We've looked at location of death. So looking at this idea of looking at aging in place. And so in our early data, it didn't change sort of if you were in Oasis or not versus like sort of aging in place. We were looking at the transitions to long-term care as one of the outcomes that we did find a difference.
You also find that a lot of people are still sort of struggling for independence, they still want to be independent and not really put into roles or.
There's a survey that was done, and it's been replicated multiple
Yeah.
times, but they did a survey and 99% of the people would like to age in their
Yes.
place. So basically, nobody says they want to go to long-term care. And I don't know anyone who's voluntarily planning for that myself. And so everything, when we think about it, I'm just gonna have a nod to, we talk about healthcare all the time, and I think we get caught up in thinking healthcare is the hospital. And I'm gonna say, from a deeply rooted community person, it's actually not about the hospital. We should be rerouting all of our finances to upstream community, both either prevention in the community or community support services that are grossly underfunded. So I actually think we're thinking of it all wrong. That part of the reason why we can't scale up is things are just so expensive in the hospital. But that's not where we should be scaling our issues. We should be really digging in, and I'm just, again, highlighting the amazing work that's being done here in Vancouver, the new strategy for older people. And when you look at where all the work's being, when you think of the focus and the city is actually involved, it's upstream work. It's hard to evaluate what doesn't happen though. That's the problem when you do prevention.
With your permission, I will not tell our partners that considering hospital not to scale up
So there's a lot of,
I'm going to please skip that.
well, I'm gonna say loneliness and mental health and prevention. I'm saying social connections. I'm just saying, I'm very passionate about the community.
Any other questions? We have time for one more at least.
So the way to know this is we have time for one very good question.
I'm hoping this is a good question. So when we are talking about making use of AI for medical purposes, it involves you processing a lot of data, big data. Like we say, it's a direct question. How are you able to ethically make use of AI without infringing on people's privacy, people's data? How are you able to handle this properly?
So when we do the work, I'm sure Catherine can also tell you a very similar story, but we have to pass through some very rigid ethics assessment. And in our case, or in most cases, we actually never use data that would be useful in identifying who the patient is. So to give you an example, when we were working, doing some work on stroke in Montreal, the ministry refused to give us data about neurologists because there was only 5 neurologists, and they thought that we were able to reverse engineer and identify who the neurologist is. So typically in this kind of healthcare context, anything that would lead to the possibility of you identifying the care provider or the patient, you don't have access to that data. If you do want access to that data, that's actually a much more higher level of scrutiny in the ethics process, which I have no patience to go through.
And I'm just gonna comment, I'm doing some other work using AI tools that aren't using AI for prediction, but looking at AI for optimization of health services, for instance. So we're looking at, I'm working with the Queen's Family Health team, and they actually have essentially a sandbox of their entire EMR that they've downloaded into a secure network. And for instance, we're looking at forms that are routinely completed by physicians to look at what forms are being completed and who actually can complete them by other team members. And then we're looking at developing with some computer scientists that I'm collaborating with, optimization for actually booking systems. So if you book with a certain form, you get rerouted to the next available appointment of someone who can complete the form. So the 2 examples we've had of AI are about prediction, but AI can help in terms of optimization, in terms of how we book patients as well. That's just one example.
I have one last question. I didn't read the right.
Okay.
So if you're collaborating with computer scientists, are you collaborating with Google, are you collaborating with OpenAI? And then also, second question, have
the project I mentioned, for the AI-assisted triage, we are using a large language model, but that large language model is developed by the technology provider and patented. So it's much smarter than ChatGPT for that particular purpose. Right? So I think ChatGPT is more for students to prepare their midterm projects. That's where it's very useful. I mean facetious. I mean it's 7:15 and I'm working overtime right now.
The other amazing use that I've been working with in our healthcare system in our region specifically has purchased something called AI Scribe, and I don't know if anyone has interacted with AI Scribe, and that is going to change also my area is primary care and thinking about how we can use technology to increase access by creating efficiencies. And I think there's two pieces with AI Scribe. One is the efficiencies, but also it changes your relationship. And that's the next project I want to look at is like, how does it change your relationship with your primary care provider when their back is not turned to the computer typing? And I myself have a position with an AI Scribe, and it has changed my own relationship when I suddenly can see that she's actually looking at me. Obviously, I have to give consent for it, but there's a lot of issues. And again, AI can be used for lots of different things in healthcare, so just thinking about some of those ideas as well. But I'd love to talk to you about that after.
Great. Thank you so much again, and for each of you for coming out tonight. Tomorrow, if any of you are joining us, we will be joined by 2 additional speakers in addition to Kerstin and Vedat. So they're also here in the room tonight, so feel free to also bombard them with questions after. We'll be joined by Milad, a PhD student of Vedat, is specializing in AI's application, and we'll also be joined by Dr. Donnelly, who's here in the crowd. He is an assistant professor at the Faculty of Medicine at UBC, as well as the managing director of BC Cancer Medical Staff Dental Association. So a really well-rounded panel discussion. So bring your questions forward, and if I don't see you tomorrow, thank you so much for joining us tonight, and thank you to our wonderful speakers. Please feel free to linger a little bit, but not too long, because our Kingston friends need to sleep. But feel free to linger for a little bit. It'd be great to meet each of you. So thank you so much.
Last night was so fantastic for those of you who were able to join us. We got to hear about Dr. Kerstin de Wit's application of AI to diagnose pulmonary embolism, and I wanted to share, I got a text last night from a friend who attended, and it was a really meaningful event for her because she actually lost her mother and sister to misdiagnosed pulmonary embolism. So incredible work led by Dr. Kerstin. And then we of course heard from Dr. Kerstin Donnelly's leverage of big data to eradicate loneliness to envision a better connected world. And then we ended with Dr. Vedat Verter's interdisciplinary approach and lens on streamlining wait times for us in the emergency room, especially with respect to mental health patients. So across the board, incredible work by our researchers here at Queen's. Before beginning, I want to acknowledge that the land on which we work and live on is on the unceded and traditional territories of the Squamish, Tsleil-Waututh, and Musqueam nations, and we're very grateful for the opportunity to do so. My name is Diana Chang, and it's a delight to be here. I graduated from Queen's in 2010, and the pre-mingling, I've been reminded of how old I am, so I find that funny. And I'm also the current Queen's University Alumni Branch President. My career kick-started at Queen's, where I had the privilege of promoting Canada, promoting Ontario, and promoting Kingston and Queen's around the world to eager recruits. I saw firsthand, however, the spirit of initiative and impact of our Queen's alumni community, championing good, opening doors, and making their own communities better, whether it was across the hills in Shanghai or it was a panel discussion in Hong Kong. Queen's is currently ranked 8th globally and 2nd in North America in the 2024 Times Higher Ed Impact Rankings among 2,100 institutions. 10 Queen's alumni were recently featured on the Maclean's magazine Power List, showcasing Canadians shaping our country. And when we think of impacting the next generation, I was reminded by a recent visit by our admissions team that we continue to surpass the national U15 average in both retention and graduation rates. I believe post-secondary's responsibility is to inspire minds and real-world impact through research, education, and leadership. And we're proud to be building a global community that fosters this creativity and innovation, as we saw firsthand yesterday and we'll see today. The Micro Summit series has 4 parts, and they're all rooted in the theme of AI and the future. Vancouver's focus, as mentioned, is healthcare. With that, I will segue us beautifully to tonight's conversation. Our theme tonight is healthcare. How are AI and census and big data making healthcare better and more accessible? Our event tonight is a fireside discussion panel that builds on yesterday's discussions, and we'll be joined by 2 Queen's researchers, Dr. Donnelly and Dr. Vedat Verter, by one of Dr. Verter's students, Milad Mirzai, and by a Vancouver-based member of our alumni community, Dr. Dan Lee. Please join me on the stage as I welcome each of you. Great. How are we all feeling? Awesome. So before we begin, I'll do a short introduction of each of our fantastic speakers. Dr. Kerstin Donnelly on my left is an associate professor in the School of Rehabilitation Therapy and Director of Health Services and Policy Research Institute at Queen's Health Sciences. Her clinical research focuses on team-based primary care and supporting older adults and individuals with chronic conditions. Catherine, for those of us who weren't here yesterday, are you able to share a high-level summary of yesterday's talk on healthy aging and OASIS?
Certainly. So for those of you who weren't here, I spoke of a program that I've been collaborating with for about 8 years now, and OASIS is a program for older adults, and it's designed to support specifically building social connections to address issues of loneliness in what we call naturally occurring retirement communities, or NORCs. So communities, neighborhoods where there's a high proportion of older adults. So the idea is built on self-determination and empowerment, where older adults design the programs around 3 pillars of activities: nutrition, social connections, and physical activity. We have an on-site coordinator, and again, it's a collaboration between community partners and landlords.
Thank you so much, Dr. Catherine. Dr. Vedat Verter, on our right, is the Stephen J.R. Smith Chair of Management Analytics and a professor at the Smith School of Business at Queen's. Vedat specializes in applying operations research and data analytics to support policymakers in the public sector. His main research areas include socially responsible supply chains and healthcare analytics. And in case you weren't here yesterday, Vedat, are you able to share a snapshot, 1-minute highlight of your talk yesterday?
So for those of you who are not aware of it, the original budget was 40 seconds, and I got a 50% on it from the Madam Chair. I talked about our AI-based, AI-assisted triage program at the Kingston General Hospital Adult Psychiatry Division, where the wait time was, at the time, 14 months on the average to see a psychiatrist, and there were 1,200 people on the waiting list. So the idea was to use AI-assisted triage to identify the patients who could immediately start a cognitive behavioral therapy program without needing to wait to see a psychiatrist, and that turned out to be about 2/3 of the patients. And of course, we have validated the AI predictions with an actual psychiatrist looking at those files, and that enables us to reduce the wait time from 14 months to 8.5 months.
Thank you so much. And Milad Mirzai on my right is a PhD candidate at the Smith School of Business working directly with Dr. Verter. Milad, can you share a little bit about your areas of research focus?
Hello everyone, I'm Milad Mirzai. I'm a PhD candidate at the Smith School of Business. I'm specialized in machine learning and optimization. I'm developing algorithms for different companies across industries such as retails, financial industries, healthcare, and I'm trying to leverage data to help the decision makers.
Fantastic. Thank you so much. Nice to see you. And our fourth panelist is Dr. Donnelly, Art Sci 07, Commerce 07, a medical oncologist at BC Cancer, a clinical assistant professor within the Faculty of Medicine at UBC, and the managing director of the BC Cancer Medical Dental Staff Association. Dr. Lee, it's so great to have you join us to give that localized perspective. Can you also share a little bit about your area of specialization?
Yeah, thanks, Diana. I'm very pleased to be here today. And, it's just, I'm so, when I go to an event like this, I'm very proud to be a Queen's alum. I graduated in 07 and, with a degree in life sciences and commerce. And that really sort of kickstarted my career because I came to Vancouver after that, and I entered healthcare consulting, which is sort of the intersection of both of those degree programs. And then life took me to medical school, and now I'm a medical oncologist at BC Cancer with a keen interest in innovation and artificial intelligence, and just ensuring that cancer care in Canada can be as good as it can be and remain world class. So those are my areas, and I'm happy to be on this panel.
Thank you, Dr. Lee. So now that we know a little bit more about our panelists, I do want to extend the invite out to the audience throughout this evening for Q&A. I will kick us off with a few questions, but if you do have questions along the way, raise your hand, and I won't give you the microphone as we have 5, but so speak loudly and we will address your wonderful questions. So let's get started. My first question is for Catherine. So in your talk yesterday, you spoke a lot about Oasis across Canada and leveraging big data and census data to do so. Can you break it down a little bit more for us? How can neighborhood data be used to foster health system planning?
Yeah, thanks for that question. And so yesterday I spoke specifically about using census data when we think about looking at small geographies to think about where older adults are living, when we think about leveraging how we might bring programming to neighborhoods. But I've been also doing quite a bit of work, and I don't know if people have followed Jane Philpott, Dr. Philpott's book, where she talked about thinking about how to reimagine how we deliver primary care, talking about neighborhood models, for instance. So just like you would move to a new neighborhood and you have a school, you would have access to a primary care provider and a whole team of primary care providers, so an interprofessional team. And so I've been actually working closely. So part of my mapping is with the neighborhoods to think about naturally occurring retirement communities. And I spoke a little bit about that yesterday. But a lot of my more recent work has actually been working with our regional systems in our province, thinking about how we can actually break down we have something called Ontario Health Teams. So if you can imagine the Vancouver Health Authorities, but broken down into much smaller units. And so if you can imagine our province, we have 187 of these units. And what we're doing is working to map neighborhoods in each of these 187 units. So we literally have neighborhood-focused planning from a health perspective. So just like you would move into a neighborhood, we're looking at figuring out where the primary care team should go so that when you move, you would actually be able to access those. So we're layering on all of the different types of, I'm going to call them building blocks in terms of neighborhoods. So neighborhoods can be all the way down to small little units where there's 400 people, and we can block those up to larger dissemination areas. They're called aggregate dissemination areas. And all of this is publicly available data. And we can also layer upon health utilization data and population chronic conditions and health population data as well. So we can know not only who lives in the areas, we can understand some of the disease profiles of the people living in the neighborhoods. And we're also layering on top health human resources and what types of programs are being offered where. So we don't have inequity in terms of how we plan our system. So I know here you've got primary care networks, and I have a PhD student actually who was head of interior health who was leading their primary care network. So I think there's a lot of opportunity here in BC to do similar things, but sort of founding on this idea of how do we understand neighborhoods to support access to healthcare?
Wonderful. Thank you so much, Catherine. Dr. Verter, what has your research indicated as clear areas that AI can maximize improvement?
So the one thing, well, two issues comes to mind. The first one is the complementarity between care provided by humans and how that can be amplified and complemented by the things that AI is good at. So there's this huge debate about certain professions disappearing and AI taking over, some of science fiction. But the idea is that what we have noticed, and as in the case of the AI-assisted triage project as well, the best results and the best health outcomes turns out to happen when AI is used to complement and amplify the physician or the specialist and basically enabler, work as an enabler of the person who is taking care of the patient. The other thing that is exciting is that basically in Canada we have a huge data advantage because the Canadian healthcare system is centralized. It actually allows us to collect data centrally, and so we could have a oversight of what is happening on the basis of a province. So the largest unit you can go in the U.S. are the healthcare networks because of the way they're organized. So yes, Mayo Clinic can look at their own data. Kaiser can look at their own data, but we can look at the entire data of Ontario or the entire data of Quebec, and that gives us actually a huge advantage in terms of using big data to train AI models and actually do more powerful things with AI. So those are the exciting opportunities for us.
Thank you so much. And so Milad, a follow-up question to that is you work so much on innovative algorithms and leveraging analytics. We both talked about the big data piece. Can you talk to us, what does impact look like?
When it's about the healthcare, for me, there are three important things. The first one that I think easy to guess is the patient's outcome. We want to improve that. So it's very important that we can leverage that data to do some prediction, but those predictions should be applicable in the real world, not only in the pilot studies. So we want to help, for instance, diagnose and a disease in the earliest stage instead of the last stage, and so that we can use better treatment for our patients. But there are two more important things, same as the outcome. The first one is equity. Usually when you use the data set in the healthcare industry, that data doesn't contain all of the people that you want to take care about them. And it overlooks some part of the population. This is not things that happen in the retail industry. You will have the sales data for all of the items. But here in the healthcare, there are some kind of people who didn't receive enough treatment. They are not, your data can't represent them. So it's very important for data scientists in the healthcare industry to consider those data also and try to include them somehow so the model can be applicable for every person. And the last part is the trust. When you want to use an algorithm, for instance, in the financial industry, as long as you can predict the stock market, the algorithm is good. Nobody cares about how it predicts. But when you want to implement it in the healthcare industry, it's different. Everybody should understand how this algorithm works. It should be transparent for the people who use that algorithm. Otherwise, they won't trust it, they won't use it. And so you should use models that you can explain them easily to the people. You can show how the algorithm thinks, what it's looking for, how it's optimized the process, and everything around it.
Thank you. Thank you for that patient outcome, making sure we have the full picture, and trust. So with that, Dr. Lee, how do you see AI helping to improve cancer care delivery in BC over the next decade? Love to hear your thoughts on the application of AI.
Yeah, there's just so many possible applications to AI in, well, all of healthcare, but especially cancer care. And, having worked in cancer care for almost 10 years now, and I think, most of you here are local from the area. I think you're well aware in BC that because of significant government funding, we're trying to bolster our healthcare system. We're trying to build our cancer programs, and so we're actually, this is a really exciting time for cancer care in BC because we're moving from our 6 BC cancer centers across the province to 10 by 2030. And I've been really fortunate over the last couple of years to be a medical oncologist who's been very actively involved in developing those new 4 cancer centers and trying to envision, what kind of innovations, what kind of, technologies, artificial intelligence, et cetera, should be integrated into these cancer centers so that the patients, the cancer patients that we have here in BC are getting the best possible care that they can. And I think there's just so much possibility there. I mean, I can just comment on a few things that I've seen that we're trying to integrate now, looking 5-10 years. Treatments, for instance, is going to be better significantly because of AI technology. We have lots of different modalities to treat cancers. And so one of them, for instance, is very precise high-dose radiation. So you see a CT scan, there's pockets of cancer, there's radiation oncologists that can use radiation to target those cancers and basically to eradicate those cancers. The way that we have historically tried to target these cancers is a very laborious process where a radiation oncologist would look at the CT scan, try and find where the cancer is, and draw out where they think the cancer is, and then sort of aim the radiation beams that way. But artificial intelligence has gone so good at analyzing imaging, and pictures, and so we're trying to integrate into our new cancer centers, as an example, technology that can help the radiation oncologists even more accurately delineate where those cancers are in the human body, and to give more a strong radiation and more precise radiation, so you get a better effect in terms of cancer killing. But then you also get less side effects because you're not targeting, tissue that shouldn't be targeted by radiation. So that's sort of one element in treatment, for instance, that I've seen. Another element is, I think we all know that in healthcare there's a lot of wait times, for instance, right? Wait time issues, and Vedat had mentioned an application of AI in the psychiatric space. But we have a wait time for chemotherapy, for instance, here. And so in the new cancer centers, what we're trying to look at right now, we haven't landed on exactly how we're going to do this yet, but there's a lot of AI models that have the ability for us to better allocate patients to chemotherapy spots, to make sure we optimize the amounts of chemotherapy capacity we have across the province. And it's been really exciting to be a part of at least some of those initial discussions on what that should look like in the province. And even just looking at my personal experience treating patients, I wish I could see more patients and also provide the best possible care that I can for all of my patients, but there's only so much time in the day. So how can I actually do this? And even though I see a very big patient volume, a lot of my time, a lot of physicians' time is spent on administrative tasks, notes, that sort of thing. And I think, Catherine, you mentioned AI scribes yesterday, and BC Cancer does not have an AI scribe now, but we are piloting models right now on which one we should adopt across the province. So this is good, and that's going to allow medical oncologists and nurses and just everyone across the cancer care spectrum to see more patients. So it's going to be lots of substantial changes over the next 10 years here.
Thanks, Dr. Lee. I really like the hopeful and positive lens you bring to the table. I want to keep drawing out the audience members for your engagement. So any follow-up questions to any of our speakers before I continue on with mine? Jess, please.
Yeah, I have a question. So I actually work in the AI space as well, and one of the things we see a lot in business is the development of agents that are doing project management tasks or doing calls at call centers. So I'm curious, within the healthcare space, where do you see the application of agents to both improve patient outcomes and any other medical?
Could you synopsize that question, please, because we can't hear.
Absolutely. So it's really looking at the application of agents within the healthcare sector and what that looks like.
Well, I can start taking this question. So across healthcare, no matter where you are, I mean, there's a constant issue, especially in Canada, of just not enough. There's not enough resources to go around, and that really applies very strongly to human resources. And so from a physician point of view, it's hard to see a physician or a family doctor or a medical oncologist or a psychiatrist, et cetera. And there's always been this question about, how can we always joke to ourselves, around the water cooler, I wish I could sort of multiply myself, how do I make it so that, I get, 50 calls into my office, I need to answer all of them. How can I sort of triage those so that, answers cannot be directly from me, but kind of from me, if I can train an agent, for example, to respond to, say, in my world, it would be, for instance, chemotherapy side effects. So I got lots of patients on chemotherapy to try and cure their cancers, and then they call into my office, and it's either usually at the end of the day I can answer them, but I wish I could, double or triple myself, clone myself to be able to answer them right away. And so I think there's a huge opportunity for developing agents somehow, across the healthcare space. And but I think it would have to, and I think Milad and Vedat, you sort of touched on this, that these AI tools have to be complementary to the healthcare providers, right? So it cannot replace the providers. And because of that, you can't just make a general agent. You can't just say, there's a general oncologist, right? Your patient, the patients aren't going to call for the general agent oncologist, right? They will want what I think, right? Because I know the patients, right? And I know this is sort of, and I know the protocols and their treatments, and I have an idea of how to, make them feel better if they're getting a side effect. So if I could somehow make an agent that understands my treatment algorithms in my head and my practice patterns, I think there'd be a much more adoption.
If I can follow on that, I think that's I think it's very important that in the health space, and a fully independent agent is not as desirable from a patient perspective, based on our experience and what you just mentioned, compared to, let's say, the call center space. So this is why I was highlighting that in my mind, AI would be best to play a complementary role to flag the physician when that's needed. So to give you an example of one of our work, again in the psychiatry space, is when the patient comes to see their psychiatrist, actually, so at an outpatient clinic, at the end of each visit, the psychiatrist actually takes narrative notes. Okay, so the patient was this, that, I saw the patient. The patient looked, well groomed, not well groomed. The patient is not taking care of herself, etc. So what we looked at is using text mining to actually capture some of the important information. Like the psychiatrist writes that, and I'm pretty sure they're so busy that they never look back at it. And the proof of that is that when you go to a physician, and with all due respect, you keep repeating the same story over and over again, they'll ask you to, the same history. So they don't have the time to actually go over those notes and try to distill what it means. So we use text mining to see if there are some important information there that could be used to predict the likelihood of patient being hospitalized sometime soon, because that's the adverse event that you're trying to avoid. So, and we were able to, find ways of identifying that. And the good way that it could be used is that the psychiatrists will do what they do. So there's no change in the current pattern of work. But then in addition to that, the agent, with the term you used, will analyze the notes and will analyze the longitudinally change in time in these notes and flag the physician if there is a important jump in the risk of hospitalization soon. So that's not an agent in my mind independently basically acting like a doctor, but it's a very important value in complementing the doctor's abilities. That's how I see it.
Thank you so much, Vedat. Just to follow up on that, I have another question actually. Is so you talk about AI within that scope of that psychiatrist. What about the challenges around getting patients to feel comfortable with AI as part of their care continuum? Can you comment a little bit on that?
Sure. So the part I didn't have a chance to talk about yesterday is in terms of the AI-assisted triage, is the survey we conducted with the patients in terms of their experience. The 100 patients who enrolled to the AI-assisted triage program that I talked about, we also surveyed them qualitatively in terms of understanding their experience with that. And interestingly, they were okay by AI assisting the care delivery process, as long as it number one, as long as it gives them faster access. So rather than waiting 8 months to see a psychiatrist, the idea of starting cognitive behavioral therapy, despite in an online mode rather than face-to-face with the therapist, is preferable, as long as there's human oversight. Like, that was a very clear outcome of the survey, that if the patient has a feeling that the human oversight is on the weak side, that actually sort of works against the trust issue that Milad mentioned. So I think the issues that Milad brought up in terms of explainability of what AI is doing, and the reason why we bring this up is because you would know deeply that there are some AI models that are not explainable, and we have absolutely no idea how they're working, but they're working well, right? So you can use them in finance, but maybe you can't use them in healthcare because you can't explain to the physician how they work.
Perfect. Thank you so much, Dr. Verter. And this gentleman had a question here as well.
Dr. Cunningham, with the thing like grabbing
It's a great point. So, and that's why it's so fascinating to think about this concept of naturally occurring retirement communities, because they're inherently intergenerational, because it's not a retirement home or a seniors home specifically. And so the idea is, by working where people are living in an intergenerational environment, it might have high proportion of older adults, but they're intentionally not seniors only. So we leverage that definitely. So the idea is that we think about how to bring in other people from the building to some of these activities as well. What we hear from a lot of older adults that are living in apartment buildings that aren't intentionally for retirement homes, that they've chosen that because they don't want to actually live specifically in a retirement home. But yeah, there's been a lot of work and interest actually on intergenerational, like how to connect older adults and young children together.
Thank you, Dr. Donnelly. Anyone else from the floor with questions? Go ahead.
So I'm Ruby. I work actually in AI in healthcare. Fraser Health, the Center for Advanced Analytics, Data Science, and Innovation. So I'm interested to hear the panelists' thoughts on the importance of AI literacy for both for patients as well as for people who work within the healthcare space as part of that change management, so that people can accept AI in healthcare.
Great. Who would like to tackle that first? I'll throw it over to Dr. Lee.
That's a good question. Change management is difficult in healthcare. Like, not just for AI, but for really anything. You ask a physician that their secretary is going to change, and they're up in arms. So it's challenging, and I think certain industries are better when it comes to change than others. And when I reflect on AI or really any technology, it's always sort of astounds me that the tech industry has gone it right from the beginning, right? They're just, and part of it's because they're privatized, and they adopt things because it's so rapid paced and they have significant competition. It makes sense. But in healthcare, and especially in Canada, because we're publicly funded, and this competition isn't really something that really enters our conversations, right? It's there's very little drive, I think, to adopt new things unless people are forced to do it, even if it makes sense, even if it really makes sense, such as some of these artificial intelligence solutions. And so I think for me, and with my clinical hat on, I think it comes down to convincing people on the adoption of AI based on the metrics that are important to them, and and that's why we sort of rely on our sort of academic colleagues, because you've got, our experts at figuring out what those are and then helping to prove that something works or does not work. But for instance, from a physician point of view, if you tell us that there's an AI solution that will improve overall survival or curability of a disease, we're going to listen right away, right? If you tell a healthcare administrator that an AI solution is going to perhaps cut costs, they're probably going to listen right away. If you tell the Ministry of Health that a artificial intelligence solution may increase the number of patients being seen in the system, then compared to what it is currently, they're going to listen right away and potentially fund it, right? So I think it really comes down to, like, what are the right metrics? Because there's a lot of metrics out there that can prove something either works or does not. And when it comes to sort of change adoption, you kind of have to speak the language of whoever your target audience is. But it's tough in healthcare. It is.
Thanks, Dr. Lee and Dr. Donnelly. Yeah, no, I'm just smiling because I agree completely. And I've been working in healthcare for 30 years myself, and it's shocking how slow things move along. I think if you understand the implementation science world, there's a whole science of how we implement new ideas and new technologies. And now this is an old study now. This is going back about 15 years, but they say it's 17 years from conception to implementation, and that's if it ever got implemented. So again, nothing moves fast, and I think that's the challenge and frustration. And I think the idea, and I see this in my colleagues, so I'm an occupational therapist, so there's a whole slew of health providers that are not physicians, and that also have to be thinking about, like, how do we change not just physician care, but when we think about access to the entire system. And when we use the terms AI to people, it's overwhelming. They don't understand what that is. And there's, even if we say AI, it means different things to each of us because it's so broad of a concept, really. I feel like what we need to do is start to unpack it very explicitly and say, instead of saying, can AI help you, like, actually name the tool and describe the tool. And that's the beginning of the change management process in my mind. And I think what the research that I see that needs to be done is actually qualitative research. Like, we need to deeply understand some of the beliefs that the different providers have, some of the beliefs that the patients have, and understand the experiences. Like, the AI scribe is a great one. Like, it can transform the relationships, but we have to figure out, like, how people are feeling about that and understand that. So I think there's a whole line of research that I think can inform how we can then further implement as well. I have some other things that I could talk on and on about how slow healthcare is and how deeply frustrating it is. I'll just say this one story, and this is the truth. So if we're talking about the Kingston Health Sciences, we just implemented, and no one will believe this here, the first time an electronic medical record system. People were handwriting up until the fall of this year. So to think of AI, again, we're just now getting into electronic medical record system. So I do a lot of work in primary care looking at electronic medical records. That's a treasure trove of data. But again, speaking of, like, what's missing and what we can't look at, there was no electronic system. So that's how slow this can be, just to kind of say, like, how can we lean into this? It's going to be interesting to see how the system actually copes.
Thank you, Dr. Donnelly. Thank you, Ruby, for the question. That leads me to
it's not fun when everybody agrees, right? So
Perfect. Throw the curveball.
So just for fun, I'll disagree with the doctor. Not fully disagree, but just mention, because this competition in healthcare is a very interesting topic, and I would not want to put the causality entirely on the lack of competition that the Canadian system is suffering from. I mean, that is one part, but the other part, and that relates to what Catherine was also mentioning, the system being slow, is, in my mind, there's so many different stakeholders in the system. And so nurses are one stakeholder, physicians are another stakeholder, administrators are, so when you were talking about the metrics, you gave different metrics for different stakeholders, which in my world means that their interests are not aligned. So they're not looking at the same thing. And on top of that, well, they don't necessarily talk to each other. So the idea is that this is not like, I think I gave that example yesterday as well. This is not like a factory where everybody from the chief operating officer to the person on the assembly line are actually working towards the same goal. Now, if you say in healthcare, they will tell you that their primary goal is caring for the patient, obviously, but then just after that, the secondary goals are actually pretty different. One wants to cut the cost, the other one wants to make sure that nurses are not overloaded. Doctors are, in the business of saving lives. So the fact that there are like so many stakeholders with very misaligned objectives creates friction in the system that doesn't exist in some other systems that makes things, in my view, work slower in healthcare. Now, again, in my view, this may not be great news for the patient, but this is great news for academics because there's lots that we can do in that domain, that there are amplitude of problems that we could look at just because the system is so much problematic, right? So it's good news and bad news at the same time. But I would gently nudge against putting competition as lack of competition as the only. Maybe that's not what you meant, but I just wanted to disagree.
Perfect. Thank you, Dr. Verter. So, Milad, I do want to come to you because I know in your world, and we spoke earlier, you bring a different lens because we can widen the lens with you because you're not focusing just on healthcare. So what suggestions do you have for ensuring alignment in metrics when we speak on metrics so we're all accountable to the same things? What tips do you have for us on that front?
So typically when I want to solve a problem in the world of the data science, the first part for me or anybody that I learned from them is understanding the problem. And usually this understanding problem is not a 1 day or 1 week. It takes at least around 40% of your time over the project. And when you understand the problem completely, the second step is defining the metric. You won't define the metric after designing the algorithm or after creating your agent. You first define your metric and then try to create an agent, create an algorithm that can maximize that metric for you. And that metric usually comes with, you're talking with all of the stakeholders. You try to check the literature. You go to, for instance, me and Vedat working with the company, try to predict the chance of pregnancy. And we see that in our project that the patient side is very important because the device that the company were using wasn't too comfortable for them. And out of 240 patients, only 80 of them use that device. So being comfortable is one part of that, which we can't see it in the machine learning algorithm. And we should think about it before that. Or the other thing is the company wants accurate prediction based on their algorithm. So you need to talk with all of the stakeholders, see all of their needs before designing anything, and make sure you understand the problem correctly.
Thank you, Milad, for the reminder for stakeholder buy-in and engagement before moving forward. Any other questions, please?
Yeah, just, you're touching on senses of comfort and trust, and you mentioned electronic medical records. Part of that was financing, et cetera. A lot of that was resistance. A lot of that was resistance because, okay, I don't have enough time to do what I'm expected to do during the day, and you want to thrust another system on me which is incomplete, inaccurate, it's going to bog down, it's going to cause problems. And I think that's going to be an issue with people when they come and say, well, we're going to start you with this whole program of AI, and they're going to go, well, you know, I get on my Google and the AI, they're not really very good. What exactly are you going to do? How is this going to make this work? And I think that is something that to get buy-in, you're going to have to recognize that you do not have working. They don't have the time, they don't have the trust.
Great. So essentially, how can we strengthen and leverage our relationship with AI rather than to fear, avoid it altogether? Who wants to tackle that? Milad?
Yeah. So the first thing, I'm going back to my first answer. The trust is the most important part, and the trust comes from the transparency. If we can show how this algorithm works, we can talk about them in a simple words, avoid using jargons and this kind of things, and try to make everything transparent for the people who use those algorithms, and for the people who wants to make decision based on them. It can be very, very helpful. If I want to give you an example, when you want to make a prediction, you have one option is using, for instance, neural network and this kind of models, but the problem is they are black box models. Nobody can understand how they work, how they give you that accuracy number and everything around it. But the simple models such as logistic regression, or the models that you can explain them in a simple words, that if, for instance, this predictor increase, the chance that you see this result will increase. So for me, it's using those algorithms is in the first step. When you get that trust, then you can go with the black box model. The second thing that I'm thinking is very important here is the AI literacy, as one of our guests mentioned. And when we are talking about AI literacy, I'm not talking about the developers or data scientists, because it's part of their job. They should know everything around the AI and what they are working. I'm talking about the physician, I'm talking about patients. We need to give some of that to some of the instructions, and those instructions should be easy to understand, not the checkbox that you are using when you want to use the ChatGPT. It's 1,000 pages and you never read it. It should be very concise and very easy to understand. And the other thing I want to go as when you design an AI agent, AI algorithm, anything like that, you are designing it as a human-centric system. You don't want to destroy the previous workflow. I refer to the project that Vedat presented last night. You are using that to improve the current workflow, because the current workflow created based on the tons of experience, and it saved numerous lives. You don't want to destroy that. You don't want to disrupt that. You just want to help to make that current process better.
Thank you so much. Sure.
So that's the technical side, and I agree with you about the concerns of not just AI, but practically every new technology coming in, including electronic medical records. There is an initial decline in the productivity of people when they start at the bottom of the learning curve for these technologies. So there is a management angle. It is the job of the managers to protect the time of the people who are engaged in these new projects. So the idea is that you're gonna do everything you're doing, and on top of that, you're gonna learn this AI system and you're gonna make it work, is actually bad management. And that is not the problem of the AI. Like, there's nothing wrong with the AI, it's just there is something wrong with the managers, because they would expect you to continue functioning the way you are, and then do this on top of that on the side. The most successful projects I have seen is when there are protected times where there's an explicit recognition by the top management that this is a new project and this is what the focus is. So for example, when the Kingston General Hospital and 5 other hospitals in Kingston at the same time launched Lumio, which is the electronic medical record, well, basically we were told that don't even approach the IT team, because the only thing they're doing for the next 8 months is this. So you protect them. You don't like continue giving IT service to everybody else. And oh, by the way, on the side you launch the electronic medical record. That would not work. So I think it's important to decouple bad management with implementation of AI. And when you do decouple that, then you can see how to attack those different problems.
Thank you, Dr. Verter. The reminder of prioritizing, and we heard from a lot here on change making. And so I wanted to bring it back to Dr. Lee and how, as we advance in Vancouver and BC, the AI advances, how will that change cancer care? As somebody that is in the community, what can we expect in terms of changes that impact us directly?
It's a bit hard to say. I mean, the field is advancing so quickly that, you know, what we think the future was going to look like last year is completely different than it is now, and it's probably going to be completely different next year. But I mean, I can hypothesize what I think an ideal future could potentially look like, you know, in cancer care, if, you know, AI was to, you know, be very rapid in its development, and we were to see some of these some of those developments transition into clinical practice quickly here in BC, for example. I kind of liked how you, Vedat and Catherine, you're giving sort of patient examples yesterday. So maybe I'll try and do something similar to that. But you know, it's so, you know, I treat 3 cancers, but my main one is breast cancer. So, you know, I see a lot of women who unfortunately were diagnosed with their breast cancer maybe a bit too late. And, you know, if their cancer were to be detected earlier, then maybe the outcome would have been maybe a little bit better, or cure versus not cure, for example. So, you know, when reflecting in Catherine, your talk, you know, it sort of made me think, well, you know, maybe in the future with looking at AI, looking at big data through census or other big data sets, are we able to identify where these potential women are that are actually at very high risk of developing breast cancer, but for one reason or another have not been identified by the healthcare system or their family doctor, et cetera, and then being able to sort of roll out our resources similar to Oasis to track these women down and say, well, you know, based on the information we know, you know, you might be someone who is a bit at higher risk, and maybe you should be getting your, you know, a mammogram earlier, or another imaging modality to screen you, as an example, right? And so, you know, in that hypothetical situation, we'll call this patient Anne, right? So if Anne were to be in that situation, perhaps we would catch a worrisome lump in the breast earlier, which would then lead her to go for a biopsy earlier for earlier detection. You know, right now, you go for a biopsy. It might take a week for a pathologist to stumble across the slides and sort of review them and make that diagnosis. But as I mentioned before, AI technology is just so good now at analyzing images that I would not be surprised if in BC very, very soon the surgeon gets the biopsy results, runs it through an algorithm, and there's a percentage likelihood of this being cancerous versus not right away. So you essentially probably get a very close to a diagnosis, if not a diagnosis, right away, which is very, very important, because we know in cancer care, the earlier you diagnose the cancer, and the earlier you provide treatments, the better outcomes you're probably going to get. And then when, you know, Anne gets diagnosed with breast cancer, then she gets referred to BC Cancer, and then she waits to see an oncologist, you know, like myself to recommend treatment. Right now in BC, depending on where you are in the province, it might take somewhere between 2 months and 6 months to see an oncologist. And you can imagine that, you know, you have been diagnosed with a cancer, you know you have that diagnosis already, and you're waiting months and months for to see an oncologist. It's unacceptable, to be honest, right? And so, you know, when listening to your example, you know, it just makes me think, you know, there's going to be for sure applicability in developing AI models to look at all of these patients that are in the queue to see an oncologist, and to intelligently select who should be seen earlier rather than later. Right now, it's very rudimentary process where a physical oncologist has to sort of vet through everyone and try and figure out, you know, who should be seen by who. But I'm sure we can improve on that. And then so Anne, if she goes through sort of one of these AI models, then maybe she would be triaged sooner rather than later if she was diagnosed with, say, a higher risk breast cancer. And then the last question is, you know, or the next question would be, you know, seeing a medical oncologist, we would want to try and give Anne the best possible treatment for her breast cancer. And treating all cancers have become so complicated over the last number of years. I think it's probably not news to all of you that developing cancers and how aggressive they are, it's sort of multifactorial, but it's sort of this combination of environmental factors and genetic factors. And we know that genetically, there's a lot of mutations that drive these cancers, and they can number in the hundreds to thousands. Many we know, many we don't know, but the amount of data, the information that we learn on what's driving these cancers just are sort of exploding year after year after year. And so when I started learning about, entering medical school over 10 years ago, there was maybe this much knowledge in terms of the genetic drivers of cancers, and now it's like this, and every year it's exponential. And there's going to come a time in the very near future that even for me, I will not be able to know everything. And so I will need these sort of decision support tools to help me with that. And so I sort of reflect on Dr. de Wit's example of diagnosing pulmonary embolism, and I could certainly use an application like that where, the genetic drivers of a cancer are analyzed, and then a tool will help me sort of sort through what are some of the mutations that are sort of more important versus less important, what drugs are out there, et cetera. So I think if it's sort of, I think really far ahead, which could be actually earlier, who knows? I think there's a lot of potential there.
Thank you so much, Dr.
Can I just say, I fully agree?
Yes, you can.
But?
There's no but. I just really, honestly, fully agree.
Okay.
Thank you. And so we've been chatting about AI literacy and AI applications. So Catherine, let's bring it back to big data. What are some concerns or areas of cautions that you would advise when folks are leveraging and using big data?
So to pick up what you had talked about in your very first introduction about what's missing. And, oftentimes, we can only leverage the data that we have. And there's lots of pieces that we don't have necessarily. And so that only allows us to look at certain people, certain types of providers, for instance. I'm going to talk also a little bit about the data. If it's we're humans and all of us come with our biases. And so oftentimes if you're training large data, from a natural language processing and training data, if the data itself is biased, then what you're getting out is biased too. And I mean, that's some of the biggest concerns, particularly when we think about some of marginalized populations, at-risk populations, and we're just highly concerned that their data isn't adequately represented in some of these models, and just really concerned about what that might look like and just perpetuating the biases that we already have. So I think that is a very big concern out there by providers. Maybe patients don't understand sort of how that could be implicated, but I know as providers in primary care that's a big concern for us. And I'm just going to talk a little bit and just bring out what you had talked about, the right provider, the right person for the right care. And how do we make a decision of who should be seen by what person? And there's a lot of missing data, and I'm going to talk about primary care because this is my area of work, and specifically team-based primary care. And this is also going to probably astound you, but we have had primary care teams for now almost 20 years. We don't know who is actually working in all the teams in Ontario. We don't know the types of patients the different types of providers see. So for instance, there could be dietitians, pharmacists, occupational therapists, physical therapists, nurses. We don't have a good understanding of what patients should be seen by what providers and which team. And so when you think about from an optimization of health human resources, we should actually figure that out. But we can't, because right now we actually don't have the data to understand what the patients, each of those providers are seeing, to understand the profiles. Because right now, health utilization data is based on billing codes. And so only certain people in the health system actually have billing codes, so they have a data trail. And so there's a whole swath of providers that we don't have a good sense of what's happening. So, thinking about how to unpack, and again, this is where some of my work is looking at EMRs and actually looking at the raw data, not just the clickings, but the actual open text data, to start to describe and understand what some of the providers are doing and what types of patient they're seeing and what they're seeing them for. And so ideally, again, using that example I used yesterday by figuring out what forms people are filling out and what other professionals might fill out forms. The ideal thing should happen is that if you call, say, for a low back injury, and there's a physical therapist on the team, you should be immediately routed to the provider that could provide the best care for that type of diagnosis. It doesn't necessarily have to be a physician. So again, because we're missing a lot of that data to make those decisions, I think that's a challenge for us right now that we really have to figure out.
Thank you, Dr. Donnelly. Anyone else? So maybe to follow up on that, Dr. Donnelly, yesterday, I'll pose this to Milad. Yesterday there was a question on cross-collaboration in healthcare and how it's a little bit siloed. Someone was asking, well, why aren't you applying what Dr. de Wit is doing in other areas? And I think Dr. Lee touched on that. Curious if you have any advice on terms of the siloed approach of healthcare and what solutions you might have or suggestions you might have in more kind of collaboration across the board.
So based on my experience, first of all, I'm going to the first project that I had in the healthcare. I thought it's exactly same as other projects that I have in retail industry, I don't know, in the financial industry. And I started digging the data, and the first thing I saw in the data was the outcome is the patient is alive or not. And it's very hard for me to see that. So I think the first thing in the healthcare industry is you need to talk with the people even before understanding the problem is understanding the domain. And it comes first before the problem. In the other industries, you can just dig the data and see what kind of pattern you can see. But here you need those advice in the first step, even before watching the data. And if I go back to one of our other projects with Vedat, when we want to predict the chance of pregnancy, we got the input from some physician. If I made a mistake, correct me please, Vedat. We were working with a physician from Harvard University, and they told us that there are specific time windows that you can use this time windows to increase the chance of your prediction. Their thoughts was very helpful, increase our prediction significantly. So I think having everybody in the same room, talking to each other and understanding their concern, understanding their input, and trying to implement them in the best way can help to have better outcome at the end of the day.
So maybe I can, if you don't mind, complement that a little bit, like taking a step back. Now, as you mentioned, Catherine, we have some issues 20 years, 30 years still on. So, I mean, I do believe that healthcare will remain siloed. And it's a fantasy to basically expect that at the end of the day, the silos are going to just disappear because of the specialized way the physicians need to be trained. I mean, like you go deeper on a certain topic, and so therefore, at that time, you have to be, as you go deeper, you're more and more alone in that specific niche, right? So, I think the way to go about it is to bring someone into a room who can understand multidisciplinary language. So that when you said, like, you talk to the physician, but then you talk to the technology provider, the key issue there is that you're able to talk to both of them. So I think, my inclination is, rather than hoping or expecting that the silos will disappear, training our people in a multidisciplinary domain so that actually they can talk to each one of those specialties and make some sense of the overall sort of picture. That's sort of where I sit.
I think we have been for over 20 years now really focused on, and I know at UBC is like this as well. At Queen's, we have interprofessional education within the healthcare system, and that is a big thrust now. And one of the core competencies across all of the health providers, if you look at their core competencies. But what we haven't done, and I can see this needs to now start, and we have a few opportunities. For instance, in the occupational therapy program, we have a whole course where we work with engineers. So we have a co-design course where we actually have a member from the community who identifies a problem, and then like an activity of daily living, a daily life problem, and the engineers and the occupational therapists work to co-design a solution. And I think we need more of that. And I think we actually need to think more from an AI lens. And I really hadn't thought of it until listening to this. Like, we think about interprofessional education, but only from a healthcare perspective. And I've been working over the last little years more and more with engineers specifically, and they have their own competencies, and they talk about interprofessional, but they talk about interprofessional between engineers. And so again, we don't talk cross-disciplinary very often. I'm one of the co-investigators in a large $120 million grant that's called Connected Minds, and it's through York University in Queens, and it's all about intersectoral thinking about AI, neuroscience, technology for a connected society. And again, we've been really trying to break down barriers, thinking anywhere from the arts to the law to health. And it's the first time I've actually seen groups of people coming together, largely because a pot of money's involved. And in order to bring people together, you have to have these intersectoral teams in order to apply for the money from this other umbrella grant. So I think we need key drivers to bring people together, and I think we have to think beyond just like health, engineering. Like we must move forward together. And I think we forget that once then you get into training, once you get into the profession, it's very difficult to find time then to learn from each other. Like you're working alongside each other, but again, you're not then exposed, for instance, once you're a nurse or an occupational therapist 20 years out, you're not thinking AI. You're not thinking about like what an engineer is doing or designing. So I think we have to shake things up.
Absolutely. And I think that brings us to a perfect close and a reminder of how the multifaceted nature of healthcare truly deserves a multidisciplinary conversation, which is what we've seen this evening. So with that, I want to say a huge thank you to Dr. Verter, Malad, Dr. Donnelly, and Dr. Lee, because I feel like very hopeful for the future that is in front of us with each of you at the helm. I invite each of you to also think about the role you want to play, whether you're in healthcare or not. In terms of the future of healthcare and the future of connection in partnership with Queens and in partnership with who you meet this evening. Please feel free to linger. Our speakers will be staying behind for a little bit. So please chat, network. And on behalf of Queens in Vancouver and Queen's University's incredible advancement team, I want to say thank you to the Vancouver community for showing up and for being part of this. With that, congratulations to the Queens team and best of luck as they move on to Calgary next as their final destination. So thank you very much.